welcome to the Department of Internal Medicine Grand Rounds. We are pleased to have Dr. Lora Thomas here today from the Division of Infectious Diseases to talk on strategies to improve immunogenicity of vaccines in immunosuppressed patients. Before I turn it over to Dr. Julie Resnicek, let me just go over a couple of housekeeping items. Mentioned before, you can come in person or call in virtually, a hybrid. We will continue that for the remainder of the time. We are looking for feedback in regards to this new hybrid approach. And so there is for those in person, there is a survey at the top in the back of the room here, or for those online, we will submit a code. We want to know how things are going, audio working, tech working, all of those things. So please let us know. We will have a chance to have a Q&A session towards the end. We'll save about 5 or 10 minutes and we'll be getting questions virtually or in person. So without further ado, I'm going to turn it over to Dr. Julie Resnicek to introduce Dr. Lora Thomas. Thank you.
Thanks, Dr. Bergman. I want to introduce Dr. Thomas. So not only is she a colleague of mine now, she's a great friend. So we were on faculty together at Vanderbilt, and then she came to VCU here in November of 2021, and we're very obviously excited to have her on our team. She received her medical degree at the Medical College of Ohio and then internal medicine training at Kettering Medical Center. She then did her infectious disease fellowship at Vanderbilt and also got her MPH while there. While she was on faculty at Vanderbilt, her clinical and research focus has continued to be in the transplant population as it is here at VCU. She served as a co-investigator in multiple NIH funded trials evaluating the influenza vaccination in immunosuppressed patients. And I think that's what she's going to talk to us about today. Again, I'm sincerely honored to introduce Lora. Like I said, she's been a wonderful friend, a wonderful colleague, and I think we've now known each other for 12 or 13 years, so we go way back. We will hand it over to Dr. Thomas.
Okay. All right. Okay. Thank you, Julie. I think hopefully everyone can hear me now. Yeah, thank you for the invitation. I think what I'm presenting today is a timely topic. I mean, as we are still, regardless of what the president says, we are still in the middle of a pandemic. I do want to talk about different strategies of how we can improve some of the vaccines and inducing an immune response in immunosuppressed population, which has been the focus of a lot of my research. Okay, how do we go to the next screen? Is there? Oh, okay, spacebar, okay. So really the only conflict of interest I have to disclose, I will talk about one of the clinical trials that I was a part of at Vanderbilt. It is an NIH funded study. However, Sanofi did provide the influenza vaccines and the HAI assays, but offered no other financial support. So it's been less than a year since this happened, but I want to start off my talk about highlighting a public figure who I think brings up this topic that I want to discuss, unfortunately, very well. So it was last October, Colin Powell's family put out a statement stating that he had died. And I included the quote from the beginning of their statement. General Colin Powell, L. Powell, former U.S. Secretary of State and Chairman of the Joint Chiefs of Staff, passed away this morning due to complications from COVID-19. He was fully vaccinated. Now, the rest of the statement went on talking about his lifetime achievements. Unfortunately, it didn't tell the whole story. He also was undergoing therapy for multiple myeloma. And in fact, he was not fully vaccinated. He had completed a 2-dose mRNA vaccine series. But by October 2021, we were giving the 3rd booster dose to immunosuppressed patients. He had not received that yet. Unfortunately, when this was put out, of course, the vaccine critics out there use this as, an example of why the vaccines don't work. But again, it's more complicated. He was immunocompromised and probably did not mount a very good response to the vaccine. So I wanted to review how immunocompromised populations, and that's a very broad topic. It includes cancer patients, both solid tumor or malignant heme cancer patients. It includes autoimmune patients who are on immunosuppression. It includes transplant patients. My focus for my vaccine research has been predominantly in the transplant population, and that will be the bulk of my talk. A lot of this information or data can be extrapolated to other immunocompromised populations, however. But obviously, these populations do have reduced immunogenicity to available vaccinations. My area of research has been what available vaccines do we have that we know work in the general population? What protocols or regimens can we use to improve the immunogenicity in immunocompromised populations? Now, of course, whenever we deal with anything with a vaccine that's going to increase immunogenicity, we always worry about how that will affect safety. And I'll talk a lot about that specifically in the transplant population or in other patients who have autoimmune conditions. And then at the end, I do want to talk about therapies, or not, I guess they're not really therapies because they're preventive, but just thinking beyond vaccinations. One of the silver linings, I think, of COVID is that it has brought up the whole topic of using pre-exposure prophylaxis with monoclonal antibodies. So as I mentioned, immunocompromised patients, they do suffer greater morbidity and mortality from most infections with available vaccines. And unfortunately, while these vaccines can work at reducing infection rates, or even in breakthrough infections, they can reduce morbidity and mortality. Unfortunately, in our immunocompromised population, they will often have a suboptimal immune response to the vaccines compared to healthy controls. Now, when I talk about these trials, it's important to note that these are immunogenicity trials. These are not efficacy trials. If you remember when the Pfizer vaccine first came out, the efficacy trial showing that it actually reduced transmission or infection rates, it had over 40,000 people. Same thing with Moderna, it had over 30,000 enrollees. So it takes very large numbers of patients to show that vaccines, one vaccine over a placebo or over another vaccine, actually reduces the rate of infection. But as some of you are aware, immunocompromised patients are often not enrolled in these studies. And also we just don't have the patient numbers to do good efficacy studies that require thousands and thousands of patients. So most of the studies I'm going to be talking about are going to be focusing on the immunogenicity. And that can be measured in multiple ways. Seroconversion is probably, or antibody response is probably the most common one that's identified. You can also look at presence of neutralizing antibodies, even T cell responses. And then, and this is not an all-inclusive list. Mucosal immunity is also a big topic, and also innate immunity related to vaccines. I'll be mostly focusing on antibody response. I do talk a little bit about T cell responses as well. And then you also have to take into account when you are doing vaccine studies or looking at a new vaccine in an immunocompromised population, you have to remember that some of these people are getting their immune system suppressed on purpose, because we need their immune system to be suppressed, either to prevent organ rejection, prevent graft versus host disease, autoimmune disease flares. So you have to take into account, if you're going to give them something that will boost their immune response, how is that going to affect not just the overall safety, but also their underlying disease or their transplant. So this study just came out looking at excess mortality in COVID-19, and it focuses on solid organ transplant recipients. They took mortality data from the Scientific Registry of Transplant Recipients, also from the CDC, And they looked at excess mortality in the first 20 months of the COVID-19 pandemic. And as you can see, the green line is just the general population of the United States. I mean, as many of you have heard, we have seen excess mortality since COVID-19 has been in our country. Also, our life expectancy for the first time has reduced as well. But I just want to highlight how much more excess mortality there's been in the transplant population. And they did break it down by organ group. Obviously, lung recipients, any respiratory virus that's going to affect the general population is going to affect lung transplant recipients much more. And they have certainly seen excess mortality from COVID-19 in addition to kidney transplant. And then also, of course, liver and heart recipients as well. Definitely have seen increased mortality in the COVID-19 era. And if you take care of immunosuppressed patients, you probably have seen this as well. Now, this study just came out from, it was a Paris study where they looked at Paris public hospitals, and they really wanted to look at ICU admissions for influenza and COVID-19 over the past 4 years. I put in this graph because it documents the number of patients with flu or COVID who were requiring invasive ventilation in these Paris public hospitals over time. And they go back to 2017. Now, during the 2017-2018 flu season, I was in the middle of a flu vaccine trial. It was a bad flu season. And as you can see, that blip over 2018 is a little bit bigger than the others. But still, when you bring in the COVID-19 numbers, they are completely dwarfed. So I wanted to just put this in here to, again, highlight COVID-19 is not just the flu. I mean, it is like nothing we've seen before. And certainly, you know, we're still in the middle of it. So now in the same study, they did look at what, if you presented with COVID or flu and you were in the ICU in one of these hospitals, what variables were associated with increased mortality. And of course, on the right, you're farther right you are, the greater risk for dying in the ICU. Now, they did look at COVID-19 infection. You were more likely to die from COVID-19 in the ICU than if you had the flu, which it was no big surprise. And of course, age was the biggest determinant as well. But organ transplant was a pretty significant risk factor for mortality. And if you've taken care of transplant patients, this is not a surprise. Now, early on in the pandemic, there was some discussion, well, how much of it is the immunosuppression from the transplant, or how much is it because transplant patients just have a lot of comorbidities that predispose you to increased morbidity and mortality from COVID. They did look at other comorbidities related to mortality in the study. And again, yes, cirrhosis and kidney failure were increase your risk of mortality, but it wasn't like the solid organ transplant group. So again, the immunosuppression is clearly making, having a role in this. So I did participate in one COVID vaccine trial. This was at Vanderbilt. This was right when the new Pfizer vaccine got approved, December of 2020. So right away, we started administering this to health professionals and to solid organ recipients, two of the groups that were most at risk. And so when they came in to get their vaccines, we enrolled them. We got blood at baseline, then blood at the time of their second dose. And then we got another one, I believe 4 weeks after their second dose. And here we looked at antibodies against the spike protein. These were people that had no history of COVID, you know, and of course this was their first vaccine. So they really should not have had any exposure to the COVID-19 antigens. But we looked at two different spike protein antibodies, the anti-receptor binding domain and also the extracellular domain. So here in blue, you can see the healthy controls. And we did try to get older healthy controls to sort of age match with the transplant patients. But as you can see, I mean, after the first dose and the second dose, they had much higher antibody responses compared to the solid organ transplant patients. for both types of antibodies. And I think the main thing I want to point out is these transplant patients were our healthy transplant patients. They were many years out, very stable, minimal immunosuppression. I think our average time from transplant was 7 years. There was kidney, liver, hearts, lungs, and still most of them just really could not mount an immune response. And our seroconversion rate in this study was about 22% after 2 doses. And we did do T cell responses in our patients as well. And I'm going to highlight it because it was interesting. So of course, they looked at proportion of CD4 cells that were reactive to the spike protein extracellular domain IgG or extracellular domain portion at the baseline and then after 2 doses. So we didn't do anything after the first dose. So again, blue is the healthy controls, red are the solid organ. So the y-axis is change in antibodies, and then the x-axis is change in the percentage of CD4 counts that became responsive to the spike protein. As you can see, the healthy controls had robust T cell and antibody responses, and there was a correlation. The better the antibody response, the better the T cell response. As you can see, our transplant patients' responses were both the antibody and the T cell responses were reduced, and there was really no poor correlation. I mean, there were some transplant patients who developed antibody responses that did not have any T cell responses, and then we had a few people that did have T cell responses but did not have any antibody responses, as you can see, sort of along that x-axis. So, and then this is from a review article that I co-authored where we looked at COVID vaccination in our malignant heme population, including those that have had auto and allogeneic stem cell transplants. This graph just highlights the seropositivity rate following SARS-CoV-2 vaccination, and this is pre-transplant malignant heme patients. These are almost all mRNA vaccines, and they did look after 1 dose, you'll see it in black bars, and after 2 doses, the gray bars. Now, again, lower than what you would see with healthy controls, but I mean, you do see a lot that are over 70%, which compared to transplant patients, that's pretty good. Now, the multiple myeloma, again, most of them had over 70%, but still lower than what the healthy controls would have been. And then what we noticed in our review is that those that had lymphoid tumors did have lower rates of seroconversion. That could be either from the underlying disease or their lymphocyte depleting therapies. So, but the same could be said of other vaccines, not just the COVID-19 vaccines, although, I mean, the COVID-19 vaccines, I mean, it highlighted well just the overall poor response that immunosuppressed patients can mount to a vaccine. But here was a meta-analysis looking at influenza vaccination and solid organ transplant. I tell people when a solid organ transplant patient gets a flu shot, they have about 40 to 60% chance of mounting a serological response to it. And of course, a normal host, it would be over 90%. So multiple things can affect or can reduce your vaccine response. I just listed a partial list of medications or conditions. Obviously, anything that is B cell depleting, rituximab is probably the most commonly used one. Multiple medications that are used now to treat like multiple sclerosis or, and of course, any B cell derived tumors will often use some B cell depleting medication. Mycophenolate, azathioprine, they're antimetabolites often used in transplant. Multiple studies have shown that, especially if they're on mycophenolate, especially more than 2 grams, they will have an more impaired immune response to a vaccine. Belatacept is what we commonly use in kidney transplant recipients, especially if they develop some nephrotoxicity from the calcineurin inhibitors. It's a co-stimulation blocker. But studies in belatacept patients have shown, especially with the COVID vaccine, it's often less than 20% have an immune response to the vaccines. Those have had CAR T, low CD4 counts, And then, of course, even T cell depleting medications like thymoglobulin, alemtuzumab. And then, of course, I mean, any malignancy is probably going to affect how you respond to a vaccine, but particularly lymphoid tumors. So before I go into the studies, I just want to highlight what the current recommendations are, particularly for influenza vaccine and COVID-19 vaccine. So for influenza, there's a very general recommendation by the CDC. All immunocompromised individuals over 6 months old should receive routine annual inactivated influenza vaccine. Now, the American Society of Transplantation, not too long ago, revised their flu or influenza vaccine recommendations, saying, I mean, you should probably still wait at least a month after transplant. And they're now saying you should be probably considering high dose influenza or a booster dose of a standard dose vaccine, which is preferred to just a single standard dose. For stem cell transplant patients, still they're recommending usually about at least 6 months after transplant, but if you do have to give it prior because you're in a heavy flu season, consider a booster dose. Now, COVID-19, it changes very frequently. But this is the most up-to-date one based on the CDC. So before the bivalent booster came out, it was recommended that immunocompromised patients receive 5 COVID-19 vaccinations, mRNA vaccines anyway. So now they're saying you should have at least had the three injections as part of your primary series. And then if it's been at least 2 months since your last, whether it's a booster or part of the primary season, you should now get the bivalent booster. So my focus, or most of my research projects have been looking at available vaccines that we have for like the general population. Can we come up with like a protocol or a regimen that can increase the immunogenicity in a immunosuppressed population? So again, another silver lining of COVID-19 has really brought attention to the importance and the utility of the booster or the additional doses of vaccine given over a specified period of time. But the other thing that's been utilized is just increasing the antigen dose of a single vaccine injection. And then, of course, there's also talk of using vaccines with adjuvant, which adjuvants are ingredients that are added to vaccines to augment the immune response. And I'll go into that a little bit later. Now, of course, vaccine technology is very broad. Of course, there are different methodologies and different vectors. But again, these are primarily the strategies that I've focused on in my research. So the booster, I'm going to start off with a study that came out looking at COVID-19 vaccine boosters in transplant patients. This was a kidney transplant study. And basically they did a basic immunization, mostly with the mRNA vaccine. So they had 2 injections. And then everyone that completed their injection series, they had serologies checked at least 2 weeks after the last injection. And if they didn't seroconvert, they gave them another injection. Check 2 weeks later. If they didn't seroconvert, they gave them another one. And if they didn't seroconvert, they gave them another one. So this is an example of just keep boosting them until you get a response. What was interesting, so that on the left is the seroconversion rate per vaccine. So the basic immunization, it was just, I think, over 20%, which is similar to what we've seen before. So those that didn't seroconvert and got a 3rd dose, slightly more of them did seroconvert then. But when you got to the 4th or 5th dose, more than half of the people that didn't seroconvert before did seroconvert. And actually they found that after the 5th dose, probably over 80% had a seroresponse. Now, some of these patients, they did reduce the immunosuppression, like they held their mycophenolate, before their vaccination dose. But for the most part, they did see, especially when you got into the 4th and 5th dose, you did see quite a, what we call a booster effect. Similar studies have been done with influenza boosters. Of course, this was pre-COVID, but these were all solid organ transplant patients, so different organs. And basically what they did is they gave them a standard dose, single dose, in half of the patients, and then they gave a booster dose to half of them about 5 weeks later. And then they looked at seroconversion rates. So with flu studies, seroconversion, the person had a greater than 4-fold rise in their titers from baseline. Then they talk about seroprotection, which just means that they had greater than or equal to a 1 to 40 HAI titer. So, and then on the right, they just looked at the geometric mean titers for the different groups. So they did see that the booster dose did increase both seroconversion, and of course, this was a trivalent flu vaccine, had 2 A strains, 1 B strain. So it increased both the seroconversion rates, slightly less seroprotection, but still an increase. And then it did increase the geometric mean titer, especially for the B antigen. So they did see improved immunogenicity in this trial. This was one of the few randomized clinical trials evaluating a booster dose in solid organ transplant. So of course, if you're going to give a booster dose in a transplant population, what about safety? What they found was safety was pretty comparable. So most of the side effects were local and they were mild to moderate. Did not see big differences between the groups. Serious adverse events occurred pretty equally. And then of course they looked at things like graft rejection, death, influenza disease, they were comparable. And again, this was not powered to show a reduction in flu. So take that as with a grain of salt, but. So next, talking about just taking a vaccine per injection and just increasing the dosage. And we already have multiple examples of this in practice, and I just included a few of these. So you have your hepatitis B, the Engerix. It is recommended that you double the dose used in the series for hemodialysis patients and also immunocompromised adults greater than 20 years of age. And then we do have the high dose influenza vaccine as opposed to the standard dose. So the high dose has 60 micrograms of antigen per strain, whereas the standard dose has 15 micrograms. So it has 4 times the antigen dose. Currently, it's approved for those who are 65 years of age or older. But as I mentioned, it is getting more and more recommended for immunocompromised groups, but particularly in the solid organ transplant group. Now, I did list the dosage of the mRNA in the COVID vaccines. I'm not showing this to promote Moderna as the high dose version of Pfizer, because they are very different vaccines from different manufacturers. But I think it is important to point out that the Moderna, the mRNA vaccine, does have more mRNA in it than the Pfizer. So Pfizer has 30 micrograms, Moderna has 100 micrograms. Now, multiple studies in immunocompromised patients where they've received either Pfizer or Moderna have shown that Moderna probably does cause better immunogenicity. And this has been one of the reasons why it's been postulated, because there is more mRNA. Now, of course, there is a slightly different lipid particle or a lipid component of the nanoparticle. So there could be other reasons, but the most common reasons postulated is it is a higher dosage vaccine. So in randomized trials, again, this is a solid organ transplant study where they did look at high dose versus standard dose. So they gave one single dose, and again, various organ groups of high dose versus standard dose. This was a quadrivalent vaccine for both the vaccines. And they looked at seroconversion and then geometric mean fold rise. And actually for all of the strains, they found higher geometric mean titers and then also seroconversion rates for the high dose. And then they looked at whether or not they seroconverted for at least 1 antigen, at least 2, or at least 3. It was significant for high dose to seroconvert to at least 1 antigen or at least 2. So it did seem to have better immunogenicity in the solid organ transplant group. So I'm going to talk about the clinical trial that I was a part of at Vanderbilt. This is unpublished data. But what we did is we wanted to take an immunocompromised population. And so in this one, we did allogeneic stem cell transplant patients. We wanted to give them 2 doses of standard dose and compare it to 2 doses of high dose. So we were doing both a higher dose of the vaccine, and also we were doing booster doses for both groups. So this is a randomized multi-center trial of adult allogeneic stem cell transplant patients. We enrolled over 120 people. And so, like I said, they got 2 doses of either standard dose or high dose flu, 28 to 42 days apart. And what we were focused on is we really want to know what's the best way to vaccinate somebody in the early transplant period. So we started enrolling people at 3 months, but we went from 3 to 23 months after transplant. And we actually, half of our cohort were within 3 to 6 months. So we really got a lot of the early transplant patients in our group. So our primary immunogenicity endpoint, we wanted to look at the visit 3 after they've had their 2 doses, the ratio of high dose versus standard dose geometric mean titer ratio. But I think what's important to, like I said, Sanofi provided the vaccines. Standard dose at that time was quadrivalent. So it had 2 A strains and it had 2 B strains. But the high dose, unfortunately, was only, it was trivalent. So it had 2 A strains and only had 1 B strain. It did not have the B Yamagata strain. But that actually turned out to be helpful because when we looked at the titers, we kind of had that control group, so to speak. But on the right is pretty much the fold change from baseline of their HEI titers. Blue was standard dose, red was high dose. So we had the H1N1 strain, H3N2, then we had the B Victoria, and then we did look at, that should be B Yamagata, not A Yamagata, to just sort of compare to see what the titers were for those that got standard dose and those that didn't get any. What we found was that for H1N1, there really wasn't a big change in the amount of full change from baseline in the titers for H1N1. We did see a rise, not so much with the first dose, but with the second dose. We did see increased titers with the high dose group compared to the standard dose for H3N2. And it did seem to last. And visit 4 was 6 months after the second dose because we wanted to look at long-term immunogenicity. And so we did see some lasting effect of those that got the 2 doses of the high dose for H3N2 at visit 4. Same for B Victoria. We did see, not so much after the first dose, but after the second dose for visit 3, we did see an increase in immunogenicity for the high dose. And then as you would expect with the Yamagata, where the high dose patients didn't get any antigen, of course, the standard dose people did have a higher immune response to that strain. And basically, this is the same data in number form. And like I said, the adjusted geometric mean ratio between high dose versus standard dose was our endpoint for visit 3, which I highlighted in yellow. So as you can see, H1N1, we didn't see a difference, but we did meet significance for visit 3 for the H3N2 strain and also the B Victoria strain. And as you can see for H3N2 for visit 4, even at 6 months out, there was still almost double the amount of antibody that those patients had compared to standard dose for. So for safety, high dose versus standard dose in this study. So what you see on the left is post-dose 1, and then on the right, post-dose number 2. And on the top, we have injection site reactions or local, and on the bottom, we have systemic reaction. And then, of course, red, of course, is high dose, blue is standard dose. Pretty comparable, although we did see more tenderness and pain with the high dose. That's been seen with immunocompetent studies, particularly after the second dose. This was not statistically significant, but overall, safety was pretty similar. And then we also looked at what covariables predicted better immune response at visit 3 for we did look at H1N1 and H3N2. So of course, the high dose titer, it did produce better immunogenicity for H3N2. Of course, if their baseline titer of the antibodies before they got the vaccine, if it was higher, for both strains, they had higher antibody response to the vaccine. It just probably is a marker for a more immunocompetent person. And then the other thing that was significant for both virus strains was time post-transplant. So for each month that you were out from the transplant, you were more likely to develop an immune response to the vaccines by visit 3. And then the other thing that we found significant was their baseline CD19 count. The higher it was, the more likely you were mount to immune response to the H3N2. So which isn't terribly surprising. Talk a little bit about adjuvanted vaccines. We have dozens of them in use. Again, adjuvants are just compounds that we add to the vaccine to get a more robust immune response, and that's through various mechanisms. But I think the most common one used is aluminum, which is used, as you can see, this is taken right from the CDC, from a lot of different vaccines that we use, including the hepatitis and pneumonia shots that we have. There is an adjuvanted flu vaccine called Fluad. It is approved for persons over 65. It has the MF59 adjuvant, which is really an oil and water emulsion composed of squalene. And then I did want to bring up, there is an adjuvanted COVID vaccine, the Novavax vaccine. Not a whole lot of data of Novavax with transplant. Mostly we've seen mRNA and some of the adenovirus vector data. But just know that there is an adjuvanted COVID-19 vaccine. So adjuvants got kind of a bad rap, especially in the transplant world. It was around the H1N1 pandemic in 2009. So when they started coming out with the vaccines against the H1N1, many of them did have an adjuvant called AS03. It's basically an oil and water emulsion, also derived from squalene. But there were 3 studies that came out like right after each other. And transplant patients showing a possibility for rejection and also augmented alloimmunity. There was one study in 42 kidney patients where they monitored anti-HLA antibodies after the vaccine. 12% developed new de novo antibodies. And then what really frightened people was a heart study. It only had 15 patients that got this vaccine. But they all got endomyocardial biopsies afterwards. 40% of those that had the vaccine were noted to have ACR. So, but the thing is that, this was during a pandemic. There were probably other variables in play causing some of these findings. And I will say there have been adjuvant studies in solid organs since then using a different adjuvant. So this was a study looking at adjuvanted versus non-adjuvanted flu vaccine and solid organ transplant. It's a smaller group, but it was randomized. And again, this is a standard dose adjuvant. It's like Fluad. It has the MF59 adjuvant in it. However, in this study, they didn't find any immunogenicity improvement, as you can see for any of the strains. As you can see in this table here, none of them were significant. And then on the right, again, they're looking at seroconversion rate for number of antigens. And while, yes, there was maybe a trend to have a seroconversion for at least one antigen for the adjuvanted group, it wasn't significant. But what they did on B is they just looked at those that were ages 18 to 64, because they noticed that those that were over 65 just had an overall poor response to the vaccine. And they did notice that there was some improved immunogenicity and seroconversion rate to at least one antigen for the group. But of course, when this study came out, people really wanted to know about safety. As you can see on the right, where they looked at adverse events, the most common ones, again, were localized, and tenderness was more commonly seen in the adjuvanted group. But all the others were pretty similar. They did do HLA alloantibody testing in the patients who received the adjuvanted vaccine. They saw no new or increased HLA alloantibodies in the group. And there was one episode of rejection that occurred 3 weeks, but it was in a patient that had one of the non-adjuvanted vaccines. So talk a little bit about the going beyond vaccinations. I mean, I've shown that there are some patients, particularly I'm thinking of like those that have received B-cell depleting therapies or those who are on belatacept. I mean, it really, just the immune responses are so poor, so just thinking about different things that we can do for them beyond just vaccination. And one of them is just give them antibody. So I want to highlight Evusheld, which is tixagevimab and silgavimab. It's two long-acting monoclonal antibodies. It's given intramuscularly. And this is really pre-exposure prophylaxis for COVID-19. And I want to highlight it because studies still show it's being underutilized. I think I'm seeing it more and more in the solid organ transplant group, but it's really indicated for anyone who's immunosuppressed and who's unlikely to mount an immune response to vaccines. I guess the other group would be those that can't get the vaccines for other reasons. But of course, one of the concerns whenever we get these newer strains of COVID is immunoevasiveness. Is it going to be active against the newest variant that's coming into the community? Right now with the Omicron 5, it seems to be effective. Although, there's always a lookout for some of the newer variants that are coming out, whether or not it will still be effective or not. How well does it work? This study came out this summer. This was a Mass General study. These were all solid organ transplant patients, so different organs. And what they did is they looked at those that got Evusheld versus those that didn't, but they did match them by organ and by number of vaccines. And what they wanted to look at was how well it worked during the Omicron wave. So overall, in A, definitely it seemed to offer protection against, and this is any infection of COVID. And then they broke it down by different groups. It was significant. It did seem to work in kidney recipients. Also worked with lung recipients. That's an important group that we worry about. Liver and liver kidney recipients, not significant, but the numbers were lower in this group. But what was interesting though, they looked at the number of vaccines that people received and how well the Evusheld still protected them. Regardless of the number of vaccines they got, Evusheld still offered protection, even those that got 4 to 5 vaccines. And it seemed to work best for those that had never had prior COVID. And then some of you might remember when Evusheld first came out, it was 150 micrograms. And then shortly afterwards, they said, no, you have to double the dose for it to be fully effective. And they actually confirmed this with the studies showing that those that got the full dose, 300 micrograms, had much fewer breakthrough infections than the 150. So, in conclusion, although they suffer more morbidity and mortality in relation to infections that we do have vaccines for, immunocompromised patients routinely have reduced immune responses to vaccines. And one of the things that can be looked at to improve the vaccine effectiveness in this group, booster doses, which we're already doing. And then, of course, you can increase the antigen dose, like I talked about with the high dose versus standard dose flu vaccine. And then I really hope that with Evusheld, we're going to hopefully see maybe more monoclonal antibodies being offered that are long-acting that we can give to people who we know can't have very good immune responses to vaccines. Maybe we can offer them as an alternative to offer them some protection. So, anyway, and that's the end.
Thank you, Dr. Thomas. Let's see if we can get some questions. We have a microphone, I think, available, or is that's all right. We will just want to make sure we repeat the question. So we'll start in the audience here. Anybody with questions?
Yeah.
Thank you for very informative. At the beginning of your presentation, you showed a slide that really there were 3 groups for excess mortality.
Mhm,
The US population,
mhm.
heart and liver transplants, and then kidneys and lung. Why the difference predominantly between kidney and liver?
Yeah.
Those are the bigger.
Yeah, and we've seen this in practice. I mean, kidney recipients who come in with COVID seem to have a tougher go of it than like liver recipients. A number of reasons. I think one is comorbidities in the kidney transplant population, and then they are more immunosuppressed. I think then, but that doesn't really explain the heart. I mean, because they're pretty immunosuppressed as well. But yeah, it's something I've seen in practice. Megan, I think you've seen that before too. You know?
Yeah, I agree. And the kidneys that are generally a lot more infection than.
Yeah, the liver. Yeah. Yeah.
Looks like we have one question in the chat. For whom are you currently recommending the bivalent vaccine to be administered to?
So any immunosuppressed patient that has had their primary vaccination series at least 2 months ago. So, that's who we're, if it's been at least 2 months from their last primary series or at least 2 months from their last booster, that's who we're recommending it in. And I think for the general population, I think it's anyone over 12.
Go ahead.
Question about that Evishield.
Yeah.
I've only ever seen it on the core handful of times.
Mhm.
My question is, what's your experience with insurance coverage for Evishield?
Yeah.
And,
Yeah, so it's been covered. I mean, it's been free through the COVID, emergency funding. Now they are transitioning more and more of these drugs to commercial, in which case, but last I heard, Evishield is still covered. I want to, is it?
I think just within the last week. with
Yeah.
the commercial side.
Okay.
So we have a little bit of a stock available for uninsured patients, that the government supplied, and they have different lot numbers, and then it's really unclear from private insurance. how they're
Yeah.
handling it.
It's a similar question in the chat. I think we answered the first part. Is there any data for Evishield broken down by type of immunocompromised status?
Well, I mean, like the data I showed, the Mass General study, I mean, it wasn't randomized. They did sort of focus it was, clinician driven. And I think the people that got it first were those that got like B cell depleting or who were on like belatacept. It does seem to, now did they break it down and look at efficacy? No, but I think that, and I'm not sure about cost analysis, but again, I mean, up until right now, it's been free. So, yeah. And like I said, we're still in a state of trying to figure out how the insurance is going to cover it. So.
A general question, not an immunosuppressed population, but in general population. A few years ago, there was some, I think, studies showing that COX inhibitors were used to antibody production. Do you think that's significant?
COX inhibitors. Yeah, yeah. Yeah, I'm not as familiar with that data. Yeah, I am about, yeah, I mean, I guess there's always going to be some medications out there that we don't think of as traditional immunosuppressants that can always affect antibody response or vaccine response to vaccines.
I have a silly question, but I work in nursing homes in geriatric medicine, and when middle of this whole pandemic, The definition of immunocompromised patient caused some concerns in nursing home patients. I think at one point the CDC had just said older age and wasn't a clear cutoff, and then they added long-term care patients and so forth. And it's created quite a havoc in terms of the vaccine requirements. Today's presentation focuses more on solid organ transplants. I think you mentioned over 65 and hemodialysis patients as traditionally being considered. But any other comments on this broadened definition of immunocompromised persons?
Yeah, I mean, like I mentioned, the immunocompromised population is very broad. And we've had this discussion in committees about, okay, so anyone on prednisone, is that immunocompromised? Well, is it physiologic dose or is it? Yeah, so it's I mean, it's, and then of course those with cancer, how recent has their treatment been? Yeah, so but I think for the most part, if they have HIV, if they have, history of transplant, they're on immunosuppressants, and then of course, that are well established. And then of course, the issue of chemotherapy, I mean, anything recent, or if they have ongoing active cancer, yeah, I think most people would consider them immunosuppressed. So, and then of course, autoimmune, conditions, if they're on immunosuppressants for that as well, so. Yeah, and then of course, because I've been on committees where we had to approve whether or not somebody could be excluded from taking care of COVID patients, and then they're on, a medication for an autoimmune condition, but it's not really considered an immunosuppressant, so that always kind of makes it cloudy. So. Yeah.
Thank you, Dr. Thomas. For those of us who are still in have presence in the primary care space, and if our patients are come in with a question of should we direct them to their organ-specific transplant physician to kind of maybe inquire more about that information?
Yeah, I mean, most of our transplant patients have been getting their infusions at the transplant clinic. Yeah. I mean, it's not an infusion, it's actually an injection, so they don't even need to go to an infusion center. So it's really easy to administer. Sure.
You can directly refer them to the AOP infusion. There's a therapy plan called Adjuvanted. This is the referral and the medication. So if you're clear that they qualify and have no exceptions.
Any other questions? Okay.
Well, thank you for having me.
Thank you, Dr. Thomas. We'll put the attendance screen back on. It's also as you're walking out, it's on the top desk up there, the QR code and things.